thank you for attending me and Noel's education session about. I also lumped in mass hemorrhage to get into it as well, in case you're interested in some mass hemorrhage knowledge.
We are.
Boom. There we go. Well, do you want to take away the micro side of things?
I can try. Alright.
Good.
So surgical specimens are pretty much always considered a deep specimen, so they get an anaerobic culture. When we are planting them in the lab, we do extra cleaning steps and use like extended gloves versus our regular gloves, just to ensure that we're not bringing in any contamination into our BSC because it like sucks in the airflow. Sterility is a major issue with that, so we always send up for anaerobes, whereas non-surgical specimens are typically not unless they meet certain criteria. With tissue samples, we ideally have small pieces of tissue that that we'll place in a tissue grinder with saline and just grind it up. And then we use the saline solution to plant on our plates.
Yeah, it's like an emulsification of tissue and saline. It's pretty great.
Yeah.
It sounds like pureeing food for babies.
Yeah. So we sometimes have two sizes of our tissue grinders. Our usual one is like a 50 ml conical tube, so it's a bit larger. But we still can only put about 1 to 2 mils of saline in it to grind it, or else it like shoots up from the thing when you put the grinder thing in there. Really technical. So once we have ground it, we take the homogenized solution and we put a drop on each of our culture plates and streak it out for isolation and incubate it. Why this kind of matters is we want small pieces of tissue because we're not on the clinical side of things. Like we kind of know what like a healthy toe would look like, but we want a small piece of tissue that is deemed by the OR staff that's like the most purulent, most likely to be infected. Because we have to take small pieces of that tissue, if we get a large piece of tissue, we take like a little from this side, a little from this side, a little from this side, and hope that what we're grabbing is going to represent the worst part of the tissue, the most purulent or whatever. If we do get large pieces of tissue, we have to add steps to consult our medical microbiologist. Typically, because it's from the OR, it's deemed irreplaceable, so we will process it, but it could potentially lead to false negative results in that, like, we're grabbing a little bit of each of the piece, so not necessarily the most purulent, infectious part of the tissue.
Because quite often things like toes, like little toes, the surgeon tells us send the whole thing.
We do not want the whole thing.
Yeah, we're kind of stuck between a rock and a hard place.
Yeah, it has happened a few times where we've had whole toes brought in.
Yeah.
Is this toe infected? It's on.
Yeah, but then we're just arbitrarily choosing where we think the infection is. And it does add an additional like sharps risk because we then have to use a scalpel that like a bunch of sterile stuff.
Yeah.
And we're doing some cutting in a BSC, so that does add an additional hazard or risk to the team.
But does the surgeon know that?
No.
That's what I was gonna say, we need to, that's where we have to educate.
I was gonna say that's a discussion that your boss needs to have with the surgeons, saying, hey, listen, this is
and
thing,
that's
and these are the risks.
And
to
even
this
in the
size.
moment too, like if you guys are in there and they say I want to
Early
send this toe,
microbes.
you can be like, oh, well
Exactly.
actually,
They do listen. They do.
actually
Yeah.
send a part of it, and then if you want to send the rest of it, maybe send it to somewhere else, like the mark.
Presumably path,
Yeah.
right? It would the remainder would probably go to path.
Yeah,
But-
which is the mark for
Yeah.
body parts.
When we consult our microbiologist, ideally our microbiologist is consulting then with the physicians, saying, you know, this it's not the best practice, and we will do our best.
Yeah.
But the more manipulating we have to do with the tissue, the more risk of potentially introducing contaminants. Also, to cut bone in a BSC on a petri dish is very hard to do. And on occasion, as we're trying to hold it with our forceps and our little scalpel, things go flying, and then it's no longer sterile, and it's just, and we have to add comments and talk to our microbiologist again. So yeah, we will do our best when we do get larger pieces to cut up to the size that we need. But we're not trained in knowing like which part is the most like infectious part. Like, I just keep picturing toes. But like if we get like if we get a piece of tissue from like deeper, like it all just looks like red, gross, squishy things. So unless it's very obviously got some like, I don't know, very obvious signs, which I don't even know what they would be,
Fried
but
tissue.
yeah, like where it's
So it's better for you if, say for example, the surgeon cuts out a bit of tissue like that. We cut it up and send 10 1 centimetre by 1 centimetre size specimens labelled superior, lateral, inferior, whatever.
yeah, I mean 10 is a lot. But
Because
yeah.
they'll say, I want to send the whole thing.
Yeah, ideally we should be just getting like a 1 by 1 centimeter piece of tissue.
Yeah.
If you do want the whole thing cultured, it would be best to have them in smaller things.
Okay.
I can see the dilemma though.
Yeah.
The surgeon wants to send the entire thing, and you're like, well, I guess either one of our teams is going to be cutting this up,
Yeah,
right?
someone's going to be cutting it up.
Yeah,
That's
but
the,
I guess it can come down to whether or not you want 10 reports
yeah.
that will give you a bigger picture of like, okay, say you have 10 reports, 2 have some like skin contaminant stuff on it, the rest are completely no growth.
Yeah.
And you can kind of evaluate that more and say like, okay, it was likely contaminated at some point.
Yeah.
Versus if you have one specimen with some skin contaminants, is that real? Is it really there and infecting the patient? Or is it just contaminants from the process and from the manipulation? Obviously, if there's an organism that we deem as like always a pathogen, like Staph aureus or something, then obviously like there's no question whether or not you're going to be treating or doing further work. But yeah, multiple specimens, especially with prosthetics and hardware, is able to tell us a bigger picture of that. So prosthetics, natives, and hardware or implants. The setup, we typically treat the same. Once the specimen comes into the lab, we clean everything, set it up to all the same things. The difference is that on a native joint or native tissue, we typically keep for 5 days in the incubators, whereas the other ones we keep longer because with foreign devices we're looking for more opportunistic pathogens, things that don't grow quickly, like Staph aureus will grow overnight. Other organisms can take up to 14 days to grow. So we do have a lot of different procedures we follow, which is why we're always calling saying, you know, was this native, was this prosthetic, like where was this located, if it's a bursa versus like an actual joint. So we ask a lot of questions sometimes or have to do some digging. It does matter for which procedure we follow for workup.
Yeah, microbiology has hundreds of procedures, and it's kind of like a giant flowchart where it's like, okay, this is this, okay, we'll go down this route, and if you have that wrong initially, you go down an entire wrong pathway. So there could be a situation where we don't know it's a prosthetic, and we've already discarded stuff by the time that this is realized, and then there could be patient harm in that instance because we don't have the specimens and it's too late to continue incubating them.
And then because we're looking for more opportunistic or fastidious organisms, even if we were to go back to the original sample and reset it up, it's possible it's no longer viable in that sample because it needs certain anaerobic conditions in order to grow. So if it's left in like regular oxygen air, it's just gonna not grow, and so then that's not providing very good patient care because
So we need to be very careful when we actually choose from the drop down, and then in the comments section, more information's better for you
Yes.
guys. Okay.
Mhm.
yeah. So yeah, native joints for 5 days, prosthetics are 14 days, hardware and other medical devices we keep for 10 days, and those are just our bare minimum guidelines. If we're still actively working an organism up, we do keep incubating to make sure that nothing is dying and that we're getting all the growth conditions to test for like the antimicrobial susceptibilities, which always takes an extra few days. So yeah.
Yeah, we have a question for you.
Yeah.
Who knows the answer to this question?
How does the lab know
Yeah,
how long
how
to
does the lab know
incubate?
how long to
Yeah.
incubate?
They pull a number out of a hat and that's how long they do it.
Five strategy.
The orders. Yeah.
Yeah.
Oh.
Yeah. So if you order something just as a regular tissue, OR tissue specimen, and you don't choose like that it's from a prosthetic hip or knee or wherever, we do try to look it up to see if we can see in the x-ray or something that there is a prosthetic or if it's indicated somewhere, but that's
So much work.
it's technically going out of our scope, right? We're going to like snoop in patients' charts, just to ensure that we're gonna follow our proper criteria, because the last thing we wanna do is at day 5, throw everything out and say it's no growth 5 days, and then find out they have a prosthetic.
So
Because-
even if we chose the wrong thing on the drop down, but in the comments, we'd written prosthetic joint,
That's
Yeah.
you guys would,
It is very helpful.
Okay.
Ideally then we will reorder it
Yeah.
appropriately, so you might see that your orders are canceled and the initial panic might be like, why did you cancel my order? Well, we need that initial prosthetic order as like a very obvious,
yeah.
we need to
okay.
keep this for a certain amount of days.
Quick question. Sorry. So you guys will reorder it then? You'll cancel it, you'll reorder it? Or is that where you're calling us?
We will sometimes call just to clarify.
Okay.
But yeah, sometimes it is just easier for us to reorder. Our screens are also, for whatever
Different.
reason, different
Oh,
than
yeah.
your screens, and sometimes we have more options, especially in related to hardware, which
Comment. Sorry, just because we just went through this, I feel like a week ago, we were taking specimens off a joint, like a jointed knee, and in our drop down, I don't think it says.
It does, it says native or
Does it?
prosthetic. It does.
Yeah.
Does it? Okay,
Yeah,
but
it
at least
does.
I know I can put it in the comments.
yes,
Yeah.
So you
if
have
you
to be cognizant of, cause there's OR and then there's
Well, I know
other
that, but yeah.
samples, but some people will choose the other samples
Yeah.
and not directly OR.
If you go into OR,
So
it's,
you might
I didn't see
be,
it in there.
yeah.
Wasn't it you and I, Mark? Me and Brent? I don't
sometimes
remember.
if you're
No,
in the wrong
prosthetic
menu,
is
you
in
might
there.
not have all the
Was it
right
you?
I've not
options.
seen
yeah,
prosthetic
and
in there.
being
No, it wasn't me.
when specimens are from the OR, to label them as from the OR is also a very important
Yeah.
step. I mean, obviously, if we're getting a deep tissue or toe, we're assuming it's not done bedside. But having it ordered from the OR is that first clue that we need to clean our BSC, wear extended gloves,
Okay.
and just make
Yeah.
sure everything is as sterile as possible. Like, we do clean our BSC, but we do an extra cleaning step prior to setting up those OR specimens.
Yeah.
Because we use it throughout the day, we just want to make sure that it's as clean as possible. So, yeah,
Yeah,
having
as
So
you
is
go,
that-
as
OR
you go down
versus
the
like
drop down,
deep or tissue.
Just one that's like selected as OR, that's what you mean?
Yeah.
Okay.
because as you go down the drop down, you'll see the stuff at the top, and then down near the bottom it says OR tissue, OR
Yeah,
fluid,
yes,
yeah.
yes, I
That's
know
the
that.
stuff that we need to do.
And I will say, like, the OR staff is very good about making sure the labels on this actual specimen and what's put into Meditech, whether it's the order or the comments, that is done almost perfectly every time. Like the specimen will say tissue 1 proximal whatever, and then the label will have that in the comments, and that is super helpful, especially when we do get multiple tissues or multiple specimens, because just labeling 3 samples as tibia, like it's then our job to determine which part that is to match it
And
up.
when you call down at 3:45, all the staff that took the samples have gone home. So the people that are answering the phone have absolutely no idea.
Yeah, so typically when we do have multiple samples, they are very well labeled, even if it's like number one on the label and on the specimen, or the Meditech order and the specimen, like that's helpful enough to know that that one goes with this order. Otherwise, like, I don't know if the doctors have, or the OR staff have like your notes saying, oh, we submitted specimens 1, 2, and 3, and this is what they are. If we mix that up, then like that can lead to a lot of confusion, I think. So for the most part, you guys do very good with that.
That's what we got for that one. Boom. We're gonna switch to the core lab, which I'm gonna try to describe despite not being in that department for a year. As much as the ER is usually the one to deal with it, the OR is also very frequently involved in mass hemorrhages if you do like exploratory surgeries, any of the sort. From our side of things, depending on staffing levels, the one tech who's working in transfusion suddenly gets extremely busy, typically. The one that I was involved in, the guy got like 22 units over 5 hours, and I was so busy that I've been told by the patient care coordinators, like, you should probably call someone else in, because I completely forgot. So on our side of things, we get very busy very quickly, and this job includes managing inventory. We do have to call the clinical pathologist, and then they will call the surgeon or the MRP and coordinate with them to determine both the best course of action for the patient, and the the other big thing is like knowing how many units we have at any given time. We are then tagging and thawing units and ordering fresh stuff from CVS.
And that comes from Calgary.
Yeah, so on that note, one of my future slides says we do not have platelets at this site. There are no platelets at EKRH, and we are roughly 6 to 8 hours away from getting platelets at any given time. There's no shorter way to do it. Platelets are only good for 5 days once they've been taken from the donor, and it's just not feasible for us to be having platelets on site at all times like it is Kelowna. So the best we can do is I'll get confirmation from the pathologist, hey, order platelets. All right, well, hopefully they know that it's 8 hours, and then lots of the times the patient is gone by the time they even arrive, and then we end up having to redistribute them to Kelowna anyways. But
And it's the middle of winter, the crow's nest passed, and the park are closed, so there's no way you're gonna get them.
there's no quicker way. The other thing on our side, when dealing with an initial draw for the grouped screen, you can see the typical order there: CBC lights, glucose, urea, creatinine, INR, HT, and FIB. And then, ionized calcium lactate, ABG, or venous. Those should be ordered at the beginning of every mass hemorrhage, and then the follow-up is CBC, INR, PTT, and FIB every 30 minutes. It is not really lab responsibility to ensure that these are ordered, and we don't actually have the ability to order things like Q 30 minutes or Q 1 hour. That's, if you bring us samples and say, hey, here's these ones, we haven't put them in yet, can you order them? We can absolutely do that, that's not a problem, but we don't actually have the ability to order them on like repeat draws. Does that make sense?
Yeah.
So I wouldn't expect the core lab team to be on top of making sure that those things are ordered. And this is obviously most conveniently done with a line, otherwise, especially if the patient's in the OR, I think wouldn't be very sterile for an MLA to show up, scrub up every, right, and definitely be on scope a little bit. That's just an important note about the tests that are done, but those tests are very important for like monitoring the patient and figuring out if the units that we're giving are working, should we be giving them plasma now? Because if for every 4 units of RBC that the patient receives, they should be getting 2 units of plasma. And we try to, like, lots of times you just end up being, oh my goodness, we gotta keep packing them in there with red cells. There are times where team members have called me like, hey, they had like 5 red cells, have you considered plasma? And I don't know if that's beyond scope to give recommendations to the physicians as to what units they should be giving.
Oh no, always question.
Yeah.
Yeah.
But that is the guidelines that we are given, is to go, like, so when they order MHP, or you guys order MHP, we tag 4 units and start thawing plasma right away. And it's 4 to 2. That's, other important note, I think I have it further on. Oh, let's tag into this. So, I know this is quite small, but at any given time, our target inventory for OPAWS is 10, 7 for negs, and then APAWS is 8, and then we carry odds and ends of A negs and Bs. When I was in the department, I'd often just not carry Bs because they were inconvenient and silly, and no one has B-type blood. But as you can see, we don't actually have that many units on site. And you can see our critical inventory of 4, 3, and 4. If we're getting down to that inventory, our capabilities to then handle a second MHP is severely limited. So lots of times the pathologist will coordinate with the clinician to make sure that we're not like, they're obviously making decisions that are far above my pay grade, but they will have to take considerations of, well, what if something else happens? What if another patient needs these? The one that I was in, I think the floors wanted some units as well, and I told them, nope, if those patients are stable, I'm not issuing those to those ones. These are all going to the guy who's in the OR. And those are some things that you can do. But this, just being a regional site of this size, these are the units that we have.
Question.
Yeah.
Do we know, do you guys also know what's infirmary and what's investment?
Yeah. If we need to, we could pull from
Draw
for.
for them? Okay.
Yeah, I mean, we could call around and ask. Lots of times so let's say a patient comes in and needs a bunch of units in like Invermere or something.
Mm-hmm.
We'll usually be coordinating with Heart to, like, if the patient's being brought here, lots of times Heart will take a couple units in a box, meet the patient halfway, and then continue onwards. But if the patient is, Dr. Manners is a pathologist, he's explained this to me multiple times. If the patient is using all the blood supply that Invermere has, they should not be in Invermere. They should be here.
What if it's too late and they can't transfer? We had this happen recently. Patient was in the middle of surgery.
Well, it's down
They-
went to Fernie.
It was Fernie. They
Mhm.
couldn't stop the bleeding.
We would hot shot units to Fern.
Well, our
Yeah.
surgeon, one of the surgeons ended up taking them
Mhm.
there.
Oh, really?
Yeah, but the lady had to be there. She had a C-section, and this was an unexpected complication. So and she wasn't well enough to transfer here by road. They ended up flying her out
Mm-hmm.
to Calgary.
Yep. We are called by the region to redistribute
Yeah.
stuff at any given
Okay.
moment. Yeah.
A bit like the dantrolene.
Yeah, usually it's just involving expensive
Okay.
hot shots, which is fine.
Saves moments.
Yep. I mean, you're asking the question, what's the value of it? I mean, if someone lives, it's pretty valuable. So,
Yeah.
important things to note about MHPs, communication's pretty important. The lab's pretty much just going to keep going until we're told otherwise. When asking team members for this presentation, a couple of them were like, yeah, I had a MHP, and then they didn't tell me it was over until like 2 hours after it was already over. I was like, oh yeah, that guy's fine. We're like, we're
still taking bags here, people.
yeah, like,
Yeah.
and we're like calling up. It's like, hey, when are you coming to the next one? It's like, well, that guy's fine. Don't worry about it. Or he's dead.
Yeah.
Sorry, the patient is expired, and then we're just not told about it, right?
Yeah.
So those things are pretty important because we do have, it's sort of all hands on deck at that point where, depending on the time of day, obviously there's more staff during the day, but the one tech could just be going crazy trying to get all this stuff ready, and the MHP could be over. So when we don't know that it's over until we are told that it is over. On the opposite side of that, if you order an MHP and go, we need this now, let's go, it is very easy for us to cancel stuff on our end. right? We would prefer the MHP to be called either prematurely or unnecessarily, and then getting stuff prepped. If we waste a couple bags of plasma, it's not the end of the world. They keep for a couple days. We can always send them out. But it's very easy for us to untag units. You just rip the tag off and put them back in the fridge. It is not a problem. So having things done earlier and then canceled is completely fine. But we will mention that the OR is also, you guys are doing a really good job on your end. You guys are really good about bringing back units that are, because once it's out of the fridge, you have 30 minutes to start the transfusion, or else we can't return it to inventory. You guys are very good at coming back and bringing it back to us within that time frame. You are also, the other things that I had staff give me feedback on is that you are very good at telling us when and where patients are going to PAR and where they are. That is super helpful, because then we don't have to go run around the building looking for these people. Like, yep, this guy's in PAR, sweet, we'll be there. That is super helpful. But that pretty much concludes all that we have.
If the blood comes down in a cooler,
Mm-hmm.
does that extend the 30-minute time?
Yeah, you can put it back in the cooler.
Yeah, so if we say we wanted 4 units straight away, send it all down. If it's in a cooler, how long does the 30 minutes still apply? Because it's out of the fridge. But it's in a cooler.
If it's in the cooler, those coolers are, presuming that it was set up properly, those coolers are set for 24 hours.
Okay, so that's an option for us, so we're not wasting.
Yeah, and I think there
Especially if we're
is,
getting to the critical
I
stage.
think there's actually new procedures coming down the lines when an MHP is initiated to just pack up a box with 4 bags in it
Yeah.
and bring it to the OR. I think that makes more sense for a site like Kelowna, where their OR is a very big distance from the lab, whereas you and I share a wall.
Yeah.
Carly, you had a question?
We also have a specimen freezer and fridge, and I have approached Tracy about this probably 2 years ago, asking like, because we don't use our fridge portion. Is it possible to get some sort of protocol in place to use our fridge if we need to get units of bloods and Renards?
I think that the fridge would probably require both accreditation and constant monitoring.
We do all that. 'Cause
Okay.
It is like that's where we put our allografts.
Okay.
It's an allograft freezer with a fridge on top. And we got that when we found out, like we used to store them in your department and they were like, this is not to accreditation standards, so we got our unit after the fact.
Does our fridge alarm if it reaches if it goes
I
out
don't
of
know
it?
the whole details
Yeah.
of it, so that's why I
Yeah.
talked to Tracy and was seeing if this was a possibility for something like MHP, and then you have your blood right there and you're not constantly.
Potentially.
So-
We'd have to take a look at what that fridge is and what the actual requirements are from the
I'll follow up with
accreditation.
Tracy.
Yeah. And touch base.
Because when we get
You may want to touch base with Jen Yordle.
Okay.
Jen is tech lead for
Yes.
transfusion.
I was talking to her last week and
Yeah.
she gave me that little rubric of your, how much blood you guys have.
Because when we get called in,
Mm-hmm.
for example, we're called in for postpartum hemorrhage. You get 2 OR nurses. That's it. You get recovery, and if it's a postpartum, if you're told what it is when you called, you can ask them to call recovery. But they get 40 minutes to come in, and some of them are coming in from Kimberley and stuff like that. So we've got limit, and the staff that are actually coming in are having to pick the case cart, get the room ready, and you can space. So they're super busy as well as
Yep.
your solo guy in the lab.
Yep.
So if some of the communication sometimes gets missed, that's probably why.
That's fine. I
Yeah.
mean, a little goes a long way.
Yeah.
Really, like,
We're doing excellent.
I'm using the one that I was involved in as examples, but I was constantly chatting with Liam, and he was very helpful.
Yeah.
So, you know, as much as it is an education session, you guys have all been doing a pretty good job in what you're doing, and essentially just keep it up, really.
Yeah.
But that's it. That's what we have for you guys. We hope it was beneficial.
Question. Thank you so
Yeah.
much. Bronchoscopy samples. I've been told that we do not enter them into the computer. We bring down the Dr. Denise's orders, and you guys put them in because we screw it up because there's so many. It's a complex entry. Is that, does that still hold?
I mean, you can definitely enter it.
Yeah.
But having the copy of the order
Yeah.
form is very helpful to us to ensure that it's been ordered appropriately and all the tests have been
Okay.
ordered. We used to have, well, like the OR typically does a very good job with orders, and it's typically the other departments that we've had issues with not ordering like fluids
Yeah.
from the OR as, or from Hemorrhage as like a prosthetic joint versus native. You guys tend to do a lot
okay.
better of a job. So you can order it if you feel comfortable doing that.
Okay.
But also be aware that we might cancel it to reorder it
If
appropriately.
we've done it
it's-
wrong, yeah. 'cause
Yeah.
it-
I do think in the new Meditech system, because I've had to chart it, when you put in something that is for microbiology, it goes like it automatically propagates into the chart.
Yeah.
It does, but I've put it under the path part, cause you can choose cyto or whatever or
Yeah.
other. So it's still charted in the patient chart, but I don't order them because I don't.
Okay,
trust
so
them,
you-
I
Yeah,
do it
so-
properly.
Yeah.
So it is still documented in the patient chart, but it's not direct to order.
Yeah, we take and they've always got, even when Brad was here, they always got his written order because it was a complex entry.
Yeah,
And-
But we
because
also
there's-
used OR manager when he was here,
Yeah.
and they didn't all just.
Yeah,
Yeah,
so,
sometimes
okay.
the specimen has to go to multiple places,
Yeah.
right? So we want to ensure that everything that's been requested has been done.
yeah,
Whereas if we just get the Meditech order, then we just assume, oh, it's only for us, we're gonna go, and then we get a call, oh, it was supposed to go for cytology. Well, we didn't know
Yeah.
because we didn't have
the
the whole
order,
picture,
no, that
right?
makes sense.
So,
Yeah, we typically like to go in, if, let's say if it's a fluid, right?
Yeah.
We typically like to enter that specimen once, so if let's say the core needs one for a white cell count, they need fluids for like a pH or something like that, I guess not a pH, but like a glucose, and then you need it for cytology and for micro, we go into that specimen once, take everything that we need, aliquot it, and then close it up, so we don't have to do it again. So just having all the recs at the same time, do
Yeah.
it once, it makes it
Okay.
easy.
So another question with formalin spills, where do we call to
I would
have-
call PATH.
call
What is it?
pathology?
Is that 6407 or
Okay.
76407? I might have that completely wrong.
Okay, so the best number is to call pathology directly?
Yeah, yeah.
Okay,
what if it's after hours?
After hours, if you call the core, we have I wrote up a safe work procedure for after hours formalin spill,
okay,
and they would call in someone from PATH who would be able to clean it.
okay.
Yeah,
Do you wanna send me that safe work procedure,
yes,
please?
I can.
So that's everything over 10 mils.
Yeah, over 10 mils,
This does not.
formalin fumes are dangerous, and over 10 mils you are required to wear respiratory equipment.
Do you guys get all the dust when you guys open those from it?
Dust.
It's kind of like white
That's
particles.
where the formalin's been exposed at the joint, it just gets a bit crusty.
It's where it's leaked out a little bit and it just.
Is that dangerous?
Probably.
Dry formalin.
Go have anxiety more time.
Probably less fumey than
No,
the
no.